Hello, everyone. My name is Caitlin Bapis-Lasky. I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our educational webinar hosted by Lymphoma Canada on Waldenstrom Macroglobulinemia. We appreciate those of you able to join us live today to learn more about the disease-specific biology of WM, and we'll examine the current Canadian treatment options available. This presentation will further highlight treatments coming to Canada and the research and results behind new therapies and clinical trials. Before I go ahead and introduce today's speaker, I'd like to provide you with a bit of guidance about the Zoom software. This virtual software does not allow you to share your video or microphone. If you do have a question, please save it for the non-Hodgkin lymphoma Q&A session following this breakout presentation. You can then ask your questions to the presenters live. I would now like to introduce and welcome our speaker, Dr. Christine Chen. Dr. Chen is the Medical Director of the Autologous Stem Cell Transplant Program and Clinical Lead for the Immune Effector Cell Therapy Program at the Princess Margaret Cancer Centre in Toronto. She is appointed as an Associate Professor of the University of Toronto and is a member of the Clinical Research Group for Multiple Myeloma and related mature B-cell disorders, including chronic lymphocytic leukemia and Waldenstrom's macroglobulinemia. Dr. Chen's interests include the evaluation of new agents in the treatment of Waldenstrom's macroglobulinemia and multiple myeloma. We thank you very much for joining us today to speak on this lymphoma subtype. I would now like to turn over the presentation to you, Dr. Chen. Thank you very much.
Thanks very much, Caitlin. I'm very honored to be asked to present on Waldenstrom's macroglobulinemia today. It's a niche disorder that has gained a lot of new insights and therapeutic approaches over the recent years. These are my disclosures. And on the slide is what I hope you'll learn from this talk. I will cover clinical features of Waldenstrom's, how to diagnose Waldenstrom's, including the critical tests that we use, and then when to start treatment. And when we do start treatment, what would be our treatment options in first line, second line, and beyond. And then I will cover a few special situations that some patients may fall into and are of interest. So what is Waldenstrom's macroglobulinemia? Well, this is a photo of Dr. Jan Waldenstrom, who was a Swedish internist who in 1944 described two patients who had nosebleeds and anemia. And he found a giant molecule in their blood, which we now know is the IgM protein. And since then, we've learned much about Waldenstrom's. It is a rare disease. The incidence is only 1 to 3 per million, and it accounts for only 1 to 2% of all blood cancers. It is referred to as a lymphoma, and a very specific type, a lymphoplasmacytic lymphoma, which describes the type of cells that we see in the bone marrow or any tissues that are infiltrated. The cells on the left are kind of what we call lymphocytes, like small round cells that are similar to what we see in some other types of indolent lymphoma. The cells in the middle are more like plasma cells that are seen more with diseases like multiple myeloma. And then you can kind of see on the cell on the right is kind of a hybrid of the two. And the reason why I point out this is that when you biopsy tissue, particularly bone marrow and Waldenstrom's, it is often difficult to tell the difference from Waldenstrom's between all these other diseases like other lymphomas and myeloma. And therefore, the morphology on biopsies is not very specific, and we very much need more careful diagnostic tests. So the tissues that can be infiltrated include bone marrow as well as occasionally other tissues, lymph nodes, liver, spleen, etc. But the other feature of Waldenstrom's is the presence of an IgM protein, and this is the picture of the IgM here, which is a large molecule made up of 5 different antibodies that are stuck together at their ends. And that's what makes it particularly predisposed to sludging in the blood when levels are high, and this is referred to as hyperviscosity. So the circulating IgM can do various things besides sludging. It can interfere with coagulation, so you are predisposed to bleeding, and also can gel when exposed to cold. So fingers and toes sometimes can have sludging of blood because of this gelling feature, which is referred to as cryoglobulins. The IgM protein can also deposit in tissues and also can react against other tissues, particularly the nerves, where the coating of the nerves is attacked by the IgM protein, and we refer to this as peripheral neuropathy. And this I'll discuss in more detail later. So as I mentioned before, the diagnosis based just on looking at cells can be very difficult to differentiate from other diseases. So we're very happy that in recent years we've identified that Waldenstrom's is characterized by a particular mutation. The MYD88 mutation is seen in the vast majority of patients. There are a number of different mutations, but the most common and the one that's largely tested in most centers is the L265P one. This just refers to the site on the gene that's mutated. MYD88 is a protein that when activated by stimulus from like infections or other diseases, the MYD88 will form a complex that ultimately leads to activation of factors in the cell that will lead to cell survival of this cancer cell. And therefore, MYD88, when it's mutated, will continuously activate this pathway and lead to continued cell survival, which is not what we want with cancer cells. And so this is the pathogenesis of Waldenstrom's, and the MYD88 mutated test has turned out to be a very useful test for diagnosis. However, as I mentioned, we mostly test for the most common variant, and there are a number of other ones that are not easily available across Canada or even globally. And why is this important? Well, patients who look like they have Waldenstrom's but don't have the most common MYD88 variant should really try to get testing for these variants, because patients who don't have MYD88, truly don't, have a different response to treatments like ibrutinib. And so it is important in predicting outcomes. We also find MYD88 useful. I mean, if you have Waldenstrom's without MYD88, then it does trigger you at least to look for other diseases a little bit more furiously, like IgM myelomas or other types of lymphoma. We also know that about 30 to 40% of Waldenstrom's patients have another mutation referred to as CXCR4. This almost always occurs in those who also are mutated with MYD88. This unfortunately is not a very readily available test either, although I know many institutions across Canada are working at establishing this as routine. And why is this important? Well, this mutation also predicts for not as rapid or as long response to drugs like ibrutinib. So once we've made the diagnosis, patients have been identified to have MYD88 or not, rarely, but they have Waldenstrom's. Then the first question is, do they need treatment? And I'd say at least half of patients don't have any of the clinical symptoms that we've already talked about. And in that case, we refer to them as smoldering, so no symptoms. And it is important for these patients to be monitored, because at least in the first 5 years, the risk of turning into or developing symptoms and developing active Waldenstrom's is relatively high, about 12% per year. And then if you've gotten through the first 5 years without progressing, then it starts to tail off and is much less common. So you don't need as frequent follow-up after 5 years. So usually for the first 5 years of a smoldering Waldenstrom's, we'll follow every 3 to 6 months, and then beyond that, every year. And then the question is, can we predict when a patient will actually need treatment? There are many studies that have identified factors that seem to predict on their own for earlier progression to active disease needing treatment. And some of these factors are listed here. The higher the involvement of your bone marrow, the more likely you're going to need treatment sooner. That just kind of makes sense. Same with the higher IgM level that you have, more likely that you're closer to needing treatment. And then other blood values like beta-2 microglobulin and albumin may also be predictive. And what I like about this model is that it takes into account 4 of our strongest features, and then it puts it into a nice online program or app that you can put in the numbers that you have or your patient has, and it will give you a general estimate. And again, this is just a guideline based on a model, but a general estimate as to how long it might be before you become active and need treatment. And it kind of lumps you into low, medium, or high risk. This is all based on evaluation of large numbers of patients that have had these features. And so this is available on, it's the awmrisk.com site, the asymptomatic Waldenstrom's risk site. And it's kind of nice for patients if you want to have some general idea of what is coming up in the future so that you can do some planning. Alternatively, it may be used just to help ease some of your anxiety, because you may find out that you're very low risk and it may be many, many years, if at all, before you need treatment. Remember, probably only about half of patients ultimately will need any therapy. So once patients do develop, or rather, when this slide shows when to start treatment, because we never start treatment if patients have no symptoms, even if some of the numbers in the blood work start to look like they're progressing. We don't jump on anything unless there's a clear reason to start. And this slide identifies the clinical and lab factors that we look for that may trigger the start of treatment. So clinically, patients may develop fevers, sweating, weight loss, fatigue. So you can imagine how these are kind of non-specific. So we usually look for other signs as well. If the IgM level is high, they may have signs of hyperviscosity, headaches, visual changes, maybe even shortness of breath because the blood is sludging as it goes to these organs. There may be some enlarged liver, spleen, lymph nodes that your doctor can palpate. And of course, what I mentioned earlier is the IgM protein can attack organs like the nerves and cause numbness and tingling in the fingers and the feet, sometimes painful, sometimes, but not commonly, associated with some functional difficulties with walking, etc. And then we, as physicians and your medical team, will look at lab factors that you might not feel as symptoms. We look for presence of that cold activation that leads to gelling in the blood. We look for low blood counts with your hemoglobin or platelets, etc. So these are all things that we would look for with regular blood tests, and we ask that you as patients watch out for symptoms. Smoldering Waldenstrom's patients need regular follow-up to monitor for these factors. And when any one of them or more arise, then we need to consider treatment. And so this section of my talk is focusing on treatment options. I'll cover traditional chemo, novel targeted therapies, and then some of the newer therapies on the horizon. So this is a slide showing our most common and our standard of care chemo regimen, which is bendamustine plus rituximab. Bendamustine is a very old chemo drug we've used for decades in various types of lymphoma. It's highly effective by itself or in combinations. It does have side effects, like low blood counts can predispose to infections, and sometimes you get rash around where the infusion is given, but it's generally pretty well tolerated. It is an intravenous drug. Rituximab, many of you will have heard of. It's an antibody to CD20, and it's illustrated here. This is the antibody here, it binds to a marker on the Waldenstrom cells, which is called CD20 is the marker. And in so binding will then recruit other immune cells like NK cells and macrophages, etc., to come and kill that cell. Its major side effect is associated with infusion reactions, kind of allergic type reactions where people can get short of breath or drop their blood pressures, maybe even get fevers while the drug is infusing. So we slow the rate down and sometimes have to give pre-medications to help manage that. And then patients also can be prone to infections. So this BR combination is our standard of care, as I mentioned. It's given intravenously for 2 days every month for a total of 6 cycles. So you're done treatment after 6 months. And I want to just make a note about Rituximab, which again, many are familiar with this now since we've been using this agent for years, is that when Rituximab is given, in Waldenstrom's, it can cause this particular feature called IgM flare, where the IgM level, and these are all individual patients with their IgM levels, and you can see that when they're given the Rituximab at the onset, that some, not all, but some will have an increase, a rapid increase in their IgM levels. And this is from one of the very first studies that recognized this phenomenon. And I put the arrow here for this patient because at the peak here, where she developed a very high IgM level, she developed hyperviscosity and needed to have plasmapheresis, or cleaning out of the protein from the blood, in order to resolve her symptoms. So what do we do about this concern? Well, firstly, we know that it's more likely in people who have high IgM levels at baseline, so generally over 50 grams per liter. And that is more common if you're using Rituximab by itself, which we rarely do these days. So it's much less common when we combine it with bendamustine. Sometimes what we do is we hold the Rituximab for the first 1 or 2 cycles until the IgM level has fallen with the bendamustine, and then we add that in. Sometimes we will plasmapherese patients, which is using a machine to clean out the IgM levels from the blood, kind of like we do for dialysis. So we'll do that before starting the Rituximab. And other times, and more commonly, this is my approach, I'll continue on with the treatment, but I'll follow the IgM quite closely. And if I see this kind of flare up, then I'll intervene with plasmapheresis at that time. And I find that I don't need to do that frequently, so it kind of saves us from having to do it routinely. So how effective is this combination, this BR? Well, the study that led to the use of BR routinely in Waldenstrom's was a German trial from back in 2013, where they compared BR to another R-CHOP regimen, which is something we mostly use for more aggressive lymphomas and is thought to be a pretty effective chemo regimen. And in fact, BR was as good as R-CHOP, if not better, and with most patients responding. And it also led to fewer side effects. So this is the study that led to BR as our first-line standard of care in Canada for Waldenstrom's. And we've since seen confirmation of this efficacy from a trial that was presented at one of our big hematology meetings in 2019. This is also a German trial. And this trial gave everybody BR, and then they were mostly looking at whether to use maintenance Rituximab. And so they randomly put people into a group that got Rituximab for 2 years or not. And I should preface this with that prior to this, slow-growing lymphomas or indolent lymphomas routinely were receiving Rituximab maintenance for 2 years after their initial chemo, and therefore we were generalizing this to Waldenstrom's quite regularly. But what this study showed is that the maintenance didn't make much difference. You can see that their curves are kind of similar and almost overlapping. So it's not necessary to use maintenance. But I think what was most important coming out of this study was that it confirmed that BR is a really good regimen, that even if, whether you got maintenance or not, your length of time where your disease was under control was in the range of 8 or 9 years, which is really good when you think that this is just a 6-month course of treatment. But there are other chemo combinations we can use. We don't use them often, but I list them here just for your reference. BDR with bortezomib, other regimens using other standard chemos like cyclophosphamide, fludarabine, and of course, we used to perform stem cell transplants occasionally. We still do so if they have concurrent amyloid, which I'll talk about later. But all of these are much less commonly used than BR, but may have particular reasons why your doctor might select one or any of these regimens for your particular use. But more often, we're now seeing the use of BTK inhibitors, particularly ibrutinib. And I showed you this slide earlier, but just to reiterate, the MYD88 mutation that we see in over 95% of Waldenstrom's patients, when it's activated, will also activate BTK. And ibrutinib is a BTK inhibitor, and therefore it makes a lot of scientific sense for us to use ibrutinib in the treatment of Waldenstrom's. Ibrutinib is an oral capsule or tablet, and when it's given by itself, it is taken continuously and indefinitely as long as it is working. It was approved by Health Canada for Waldenstrom's as a single drug a number of years ago, and then more recently was confirmed efficacy in combination with Rituximab in 2019 based on the INNOVATE trial, and that's displayed here. This was a center that or study that we participated in, where patients were randomly assigned to receive ibrutinib plus Rituximab or just Rituximab alone, which is a regimen that we don't use much anymore, but was still at that time a fairly common regimen. And what this slide shows, this is the progression-free survival, which basically just shows you a big split in the curves, suggesting that the ibrutinib arm, which is in green, is far superior. It leads to a much longer duration of response than just Rituximab alone. And most recently, we've had follow-up 4 years out from this study now, and most patients are still responding. So really, really excellent outcomes with ibrutinib. Now, some of you may ask, well, do we need to use the Rituximab? And what we've learned from other studies in Waldenstrom's and other diseases is that the addition of Rituximab probably does not add too much more to single agent ibrutinib. So most of us are not bothering to use the Rituximab part. What are the side effects of ibrutinib? Well, overall, it is a very well tolerated drug, but it can cause some side effects. About a quarter of people will have diarrhea, some achy joints, mild nausea, high blood pressure. The ibrutinib can cause easy bruising, much like if you're taking aspirin, and it can cause some problems with the heart rhythm in up to 15% of patients. But overall, it's pretty easy on blood counts, which is much less common than chemo regimens like BR. So most of these side effects are pretty minor. They're usually quite tolerable. However, if you think about it, ibrutinib is given continuously long-term, potentially for years, and therefore even minor side effects can sometimes be quite annoying and can affect quality of life. And therefore, we're really happy that we have access these days to newer BTK inhibitors that are not so, don't bind to so many other proteins. And this is ibrutinib, where you can see that it's the red dots to show all the different targets that it can inhibit. And not all these targets lead to anti-cancer effect, whereas drugs like acalabrutinib and zanubrutinib are much tighter in what they target, so that there's not so much effect on non-cancer tissues. And therefore, we expect equal potency and less toxicity. And in fact, that is what we've been seeing with agents. I'm just going to highlight zanubrutinib because it is Health Canada approved in Waldenstrom's. And based on the ASPEN trial, where Waldenstrom's patients were randomized to receive either ibrutinib or zanubrutinib. And what this trial showed is that the responses were similar. And in fact, zanubrutinib might have led to slightly deeper responses than ibrutinib. So the dark blue is the VGPRs, so signifying over 90% drop in their IgM protein versus only 17% with ibrutinib. So a little bit better. And there was no difference in how long the drug worked and kept the disease controlled. So really, really encouraging data that this is just as good as ibrutinib, but perhaps even a bit better. And when you look at the toxicities in overall, the side effects were less common with zanubrutinib for the side effects that we often worry about, like atrial fibrillation, which is that heart rhythm abnormality, diarrhea, bleeding, high blood pressure. But the trade-off is that zanubrutinib does increase your risk of low white blood cell counts. And when we see that, we worry about it causing infections, but in fact, the rate of infections wasn't different between the two. So that's encouraging. It also this study showed that the number of dose reductions or people having to stop the drug due to side effects was much lower with zanubrutinib. And again, really important for a drug that you have to take continuously for many years. So as I mentioned, zanubrutinib is Health Canada approved in Waldenstrom's, and we're actually quite pleased to say that we were the first country to gain this approval status globally for Waldenstrom's. So how do we choose between chemo and new BTK inhibitors? Well, it is largely a decision that's in the hands of patients and their caregivers and healthcare providers. We know that BR is nice because it finishes in 6 months and then you're free of treatments for potentially years. Overall, from a healthcare perspective, it's pretty economical because it's just 6 months of treatment. It works quite well in patients who don't have MYD88 or have the CXCR4 mutation, where I mentioned before, they may not do so well with BTK inhibitors. And we've had many decades of experience with BR, so it's just a drug that's quite familiar to us. As opposed to BTK inhibitors, you can't beat taking a pill. It's pretty easy, and even though I went over some of the side effects, it is very well tolerated, even in very elderly or frail patients. And as I've shown you, highly effective. So we can't give an answer which is better, one over the other, but certainly it's nice to have these options, and the choice can be personalized to each patient. But what's new and exciting? I think that this is a drug that many people have heard of, was previously referred to as Loxo 305, but now named as Pirtobrutinib. It also is a BTK inhibitor, but where the problem with ibrutinib and zanubrutinib is that when it binds to the BTK protein, mutations can arise that lead to weaker binding. And so the ibrutinib and zanubrutinib, acalabrutinib can all fall off and not be very effective. And that's the main reason why people no longer have responses to ibrutinib over time. Pirtobrutinib does not bind to the same site and therefore can be effective even in patients who are failing ibrutinib. And from early data, the Pirtobrutinib is very well tolerated, much lower rates of all the toxicities we've talked about. So we're looking ahead to this drug with great enthusiasm. Many of you also have heard of Venetoclax. This is a drug that we use a lot of in other cancers, particularly chronic lymphocytic leukemia, that is in many ways kind of similar genomically to Waldenstrom's. This is a BCL2 inhibitor. So what Venetoclax does, or rather what BCL2 does, is it binds to proteins that then lead to normal cell death. So BCL2 actually inhibits that. And if you inhibit normal cell death, then cancer cells just live forever, which is not what we want. So what Venetoclax does is it binds instead to that same spot so that those proteins that were kind of inhibited to cause cell death can work. And then the cancer cells will die appropriately. And this has been a very effective treatment for many cancers. Its main side effect is when you start it up, it can kill cancer cells so quickly that a lot of the dead products from the tumors will cause some kidney blockage. But we can manage that by starting low with the doses and building up over 5 weeks. It's not yet approved in Canada for Waldenstrom's, but there are data that I'm showing you here, just early phase data that shows really good responses. These lines represent individual patients with the drop in the IgM levels, and you can see it in a different way here. Very dramatic decrease in the involvement of the bone marrow as well with the start of Venetoclax treatment in Waldenstrom's. So more to come from that as well. And then lastly, I'm just going to cover some special cases, the sludging of the blood, hyperviscosity, peripheral neuropathy, Bing-Neel syndrome, which is central nervous system involvement of Waldenstrom's, and then a particular complication called amyloidosis. This may apply to some of you, but certainly not all. Hyperviscosity, I already mentioned, is when the IgM level is quite high and it can cause the blood to get very thick. And then it causes sludging of the blood, so the blood flow doesn't go properly to organs like your brain. You get headaches, blurred vision, confusion. It can block off to your lungs and cause shortness of breath. This is just a picture of 2 tubes and showing that your plasma, which is just the clear liquid part of your blood, is normally just like almost like water. But when you have hyperviscosity, it's sludgy, almost like jello. And it's hard to diagnose this. We do a blood test that looks at viscosity, but it's not always available quickly. It can take a day or 2 to get results back, so that's not fast enough. So one of the things that we rely on is getting good historical story from patients if they complain of headaches or confusion or blurred vision. We really do jump on a clinical diagnosis of hyperviscosity. But we can also look at the back of the eye like your ophthalmologist does. And if the blood is sludging, it can cause small blood vessels to burst. And we can see these hemorrhages here. And that is why we often insist on taking a look in your eyes to see if there's any evidence of this. Because once we see that, then we need to move fairly urgently and we implement plasmapheresis, which I mentioned before is the use of a machine that cleans out the blood and removes that extra IgM protein. And it can drop it quite quickly, and patients can develop resolution of their symptoms, within hours of getting plasmapheresed. So this is the procedure that I mentioned that we sometimes will do before starting Rituximab, because Rituximab can cause that flare. in patients who have a high IgM level at baseline. So peripheral neuropathy is also another complication that afflicts a lot of patients and is really frustrating to manage because there is no really good one treatment. About 20% of Waldenstrom's patients will have some signs of neuropathy with numbness, tingling, burning, usually of the fingertips or the toes, but it can move more closer to the center of your body as well. Rarely do people have weakness or difficulty walking, but it can happen. And then that's at diagnosis, and then up to 50% will eventually, during the many years of life, develop some sign of neuropathy. And there are many different reasons why this happens, but the most common one is that the IgM antibody will attack the nerve coatings. And you can see this is a nerve biopsy that's been stained. You can kind of see the cross section of the nerves, and that when we stain it, the coating of the nerves is really thickened from the deposition of that IgM protein. So what do we do? Well, as I mentioned, treatment is really challenging. We often will try to remove the IgM with plasmapheresis, often given over several days, and see if that even helps. If it does help, it is only temporary, but it at least gives us impetus to treat the underlying disease, because if removing the IgM protein doesn't do very much, then we may not be that successful in treating the underlying disease in terms of improving the neuropathy symptoms. Rituximab alone may be useful, but we also do try other agents like steroids, fludarabine, and even infusion of antibodies, the intravenous immunoglobulin. And the goal really is to try to get that IgM protein down as much as possible, but it really is hard to do so. And as a result, we often have to use supportive therapies to help people live with the numbness and tingling. If there's tingling or pain, then drugs like gabapentin, pregabalin, these are actually seizure medications. They kind of dampen the nerve activity. And so if you have tingling or pain, which is really overactive nerves, then these drugs can be very helpful to settle that down. And we also find that patients anecdotally tell us that if they exercise or they put warmth on their fingers or toes, then it really does help with symptoms. Bing-Neel syndrome is rare, but when it does happen, can be really challenging. It is involvement of the central nervous system. So when I talked about nerves, etc., that's peripheral nerves. Central nervous system is involvement of the brain or the spinal cord. And most patients will actually not, at the time of the presentation, will not have other signs of Waldenstrom's. They'll just have signs related to the central nervous system involvement, such as confusion or memory problems or feeling off balance. And so testing for Bing-Neel really requires us to do better imaging with an MRI of the brain and also, or the spinal cord. And we often will do a lumbar puncture or spinal tap. And this is just what we see. Spinal tap should just be like water, and we don't see cells typically there, but when there is cancer in the fluid, we'll see these clusters of cells that will stain similarly to the Waldenstrom cells. And what do we do? Well, we're fortunate that we have many drugs that can go into the brain area. But more recently, ibrutinib is really our treatment of choice. And this is one of the first reports showing a patient with, you can see all these kind of black sections here that are that basically show involvement of the brain. And then on the PET scan, you can see all the yellowy parts are involvement. And that with just ibrutinib alone, a pill, you can see improvement here of the scan with much of the yellow part kind of disappearing. So really, really impressive outcomes with ibrutinib. And then lastly, amyloid is a rare complication where the part of the IgM protein, mostly the light chain part, will deposit in this kind of fibrillar pattern in different organs. And the most worrisome organ is the heart. And then those organs don't function properly. The best way to diagnose amyloid is to do a biopsy of any tissue that's involved. So anytime we see a patient with Waldenstrom's who has a heart problem or maybe enlarged glands or something that's a little bit atypical for standard Waldenstrom's, we may biopsy tissue and look specifically for this particular pattern of this kind of fibrillar pattern that reflects a bit greenish. This is called Congo red stain. If we can confirm amyloid, then it is very important to try to get rid of that IgM protein as much as possible. And there are all sorts of very effective treatments, including bortezomib, daratumumab, and of course stem cell transplant that we might use in someone with amyloid and Waldenstrom's that we would normally not use if you just had plain Waldenstrom's. So that's a very brief overview there. So I'd like to conclude by saying that Waldenstrom's is now recognized as a unique disease genetically and clinically. We're no longer relying on treatments that were used for other types of lymphoma and trying to generalize to Waldenstrom's. We actually have more and more trials now with treatments being tested only in Waldenstrom's patients. So very exciting data, many recent advances in the understanding and management of Waldenstrom's. And I hope I gave you a bit of inkling into some of the exciting new treatments that we hope will soon be available. So I'd like to just acknowledge my colleagues at Princess Margaret who treat Waldenstrom's both in the lymphoma and multiple myeloma program. And thank you very much for your attention.
Thank you very much, Dr. Chen, for your excellent presentation on Waldenstrom Macroglobulinemia. We really appreciate your excellent review of this lymphoma subtype, detailing the different treatment options that are available to patients in Canada, both in the frontline and relapsed refractory settings, and also really highlighting the newer treatment options that are becoming available for Canadians. So now I would like to go ahead and direct our audience to please go ahead and attend the breakout session on non-Hodgkin lymphoma to have your questions answered by a live panel of hematologists and medical oncologists. Thank you very much, everyone, for attending, and thank you very much, Dr. Chen, for your excellent presentation.
Thank you.